This is a brief review of the mental status exam. Um, Hopefully it will provide you with some helpful little tidbits if you're just starting out as sub-I, and you're like me and it's been, gosh, I don't know, 9 months in between, and you're, kind of peering through the cobwebs that are your mind and trying to remember something that you learned in November last year. So for the mental status exam, these are the questions that I ask every morning in order to be able to document a proper mental status exam. You're going to want to ask about mood. How are you feeling today? And I always try to encourage patients to use a real feelings word. Otherwise, you're going to get statements like, I'm fine, and I'm good, which I don't know. I just don't feel like that's a really helpful thing to document. So try to get more information. The next thing you're going to want to ask them about is SI and HI. And I like to preface this every time with, safety is something that's very important to us. Have you had any thoughts of suicide? Any thoughts of hurting yourself? What about hurting other people? And then it is really easy, I think, for patients to shut down this question by saying no. So a good follow-up, if you feel like someone's being a little reticent and doesn't want to give you a full answer, is to say, oh, okay, well, that's great. Do you mind if I ask a follow-up? How would you feel if you didn't wake up tomorrow? How would you feel if you died tomorrow? And sometimes a patient who says, no, I don't have any thoughts of hurting myself, will be more willing to say, you know what, I would love that. Life's really hard right now because of the bills I gotta pay and the fact that I'm stuck in here with you. So I definitely encourage you to, it's an old sales technique basically, try to avoid asking questions, or at least try to use follow-up questions where someone can't give you a easy answer of no. The next question that I think is really important to ask is audio and visual hallucinations. If this is a patient that you've been seeing for a while, I think you can ask those as a bare minimum. If this is a new patient, go ahead and try to incite information about other hallucinations, so gustatory, somatic, and olfactory. And again, this is an area where if you have a patient with a documented history of audio hallucinations who just came in after not taking their medications for 6 months, don't ask them, hey, have you been hearing voices? Instead ask, so tell me about these voices that you hear. Are they male? Are they female? How many are there? What do they tell you? Have you ever had a scary voice in your life? And then same thing with visual hallucinations. Have you noticed any shadows here in the room? That might be a more engaging question to ask than, do you see things that other people don't see? Obviously, when you're rushed for time in the morning, sometimes the best you're going to do is the best you're going to do, but try to challenge yourself to ask things in a way that's going to elicit the most information possible. The next thing you want to cover is, tell me about the events that led to your admission. Tell me about why you're here. And this is going to help you assess for orientation because you need to understand their understanding of the situation. It's going to assess for insight because they can't have good insight if they don't know why they're here. And it's also going to potentially allow you to assess for judgment because then based off of their response to that question, you can ask them follow-up questions of, okay, well, what do you think went wrong in that situation? In the future, what are you going to do differently? Do you have any coping mechanisms that you've developed over the last week here on the unit, etc., etc.? So with that, you've covered really like the bare skeleton of your mental status exam, except for you need to ask about, and this can be at the end because I think patients sometimes find it tedious, but you should still ask. Ask them like where they are, ask them the date, and then ask them a memory and a concentration question. So 3 objects, or remember 3 words. And then also the concentration question. What I've been encouraged to do by my residents is either use world backwards or serial threes from 20. I don't know about you, but my school taught us to do SPs where we did sevens from 100. But when you're working with this population of patients who maybe didn't finish high school, you're not assessing their math skills, you're assessing their concentration skills. And so using maybe a little bit of a more approachable numerical value is a good idea. In terms of documenting your mental status, let's get into that. So the first thing that you want to document is general appearance. That's your first bullet point. And for this, people may have different styles. Your attending might say something different, but what I've been taught is mention race if race is obvious. Otherwise, don't. Like, you can't tell if someone is Native American. You can't tell if someone is Chinese. Maybe you can. Actually, that's an interesting topic. That would make a really good letter to the editor for the APA of insight into race, if you're maybe not good at identifying it. Anyways, that's an example of a tangential thought right there, ladies and gentlemen. Anyways, so identify race to the best of your ability. Don't state exact age because you can't tell based off of looking at someone how old they are. Instead, document young, like young adult, teenager, adult, geriatric, child. And then are they older or younger than stated age? And then you want to get into identifying characteristics. Any notable tattoos? Are they wearing street clothes versus a hospital gown? Are they wearing it in an appropriate fashion? Are their genitals exposed? Do they have any odors? Are they well groomed, etc., etc.? The next thing you're going to look at is attitude and behavior. And for attitude, the two first things you need to document are cooperative versus uncooperative. I think that creates a good baseline for the reader. And it's maybe unfair to limit the category to like a binary like that, but work with what you're given. And then eye contact. Do they have poor eye contact, fair eye contact, overly intense, inappropriate eye contact? And then I also like to use one other term in there. And this will be kind of a descriptive term to describe their attitude towards you. Are they friendly? Are they maybe domineering? Are they guarded? Are they sarcastic? Just one more kind of general, broad, summation word to give an understanding of what your experience with them has been. And then for behavior, you might say how they're seated. Does their body language, is it very closed off? Are they playing with their fingers a lot? Are they sucking their thumb? Are they sneezing really often? Are they burping? Anything like that. And that's going to be a little bit different than psychomotor activity. I think that for psychomotor activity, what I'm looking to describe is basically any sort of behaviors that could potentially be ascribed as a medication side effect or as a direct result of their disease process, whereas behavior is not necessarily related to either of those things. So any EPS symptoms, tardive dyskinesia, restlessness, akathisia, pacing, any tremors, any chorioid movements, any athetosis, any rigidity, so on and so forth. And then if not, I just document no EPS symptoms, but feel free to be more thorough than that. The next thing is speech, and for these next couple, I think of them as like, I'm describing them in like dimensions, like in terms of axes. For the speech heading, I think about fluency or prosody. I think those are pretty interchangeable. And that's just how fluent is their speech, like what do they sound like? Are they maybe native English speaker? Do they have any limitations in that sense? And the next one is going to be spontaneity. Do you have to pull language from them? Are they giving you one word answers? Or do they kind of yammer on a little bit, right? And then the next one is rate, latency, and volume. And for that, I think it's fairly easy to assess. For rate and latency, what I think about is that the two are kind of always in opposition, like trains in the night. So for rate, as rate increases, your latency decreases because the space between words, the gaps you give in a conversation to allow someone else to speak, become more and more limited. And by the same token, when someone has, maybe very severe psychomotor effects from depression or thought blocking in schizophrenia, the rate that they use language will slow down. And that will be reflected in a decrease in rate and an increase in latency. The next two headings are related, mood and affect. So mood is the patient's stated description of how they feel, and if you're using the kind of assessment questions I listed in the beginning, you'll always have that covered. And so for mood, you always want to document it as a direct quote from the patient. And then for affect, again, I think about like we're describing these very tenuous, hard to hold on to and grasp ideas, and so we have to describe them in terms of multiple dimensions. And so for affect, your affect exists within a spectrum, and it's the purported expression of someone's mood based off of kind of all of those unspoken factors, whether it's their behavior, the way they're seated, their tone. It's kind of something you gauge from the gestalt of all of that. And so it can be either euphoric, which is, on the happier side, euthymic, which is somewhere in the middle, and dysphoric, which is going to be on like the lower end. And I remember when I was first learning about the mental status exam, I felt really uncomfortable with putting so many people in euthymic, but euthymic is just normal, so that's where a lot of people are going to be. And then we start describing it in terms of congruency. Is this expressed mood the same as their stated affect? And then we're also going to describe it in terms of range. And for this, range can be either maybe wide, or it can be restricted or constricted. It can be blunted, or it can be flat. And I was told that flat and blunted are going to be more rarely seen. Flat is going to be nothing. This is a patient who's severely catatonic, and blunted is really not that far from it. This is someone who maybe has gotten the first 2 or 3 doses of Ativan, and signs of life are appearing, but these aren't terms that you're going to like very freely use. This is kind of a rarity. And then constricted and restricted are going to be a bit more often seen. But you also want to think of them in terms of like the appropriateness, given how a patient feels in the moment. Like, is their restricted affect maybe appropriate for the situation? Something to think about before you necessarily call it abnormal, in an abnormal range, like constricted. And then the last thing, and I think of if range is the area or the distance covered by their mood, then lability is the velocity at which they move from one point of the spectrum to the other. And so if you have someone who has a more restricted or constricted range, but they're still bouncing within that that surface area pretty quickly, they can still be labile. And so that's, I think, probably one of the more nuanced presentations that I'm still not great at assessing, but it's just something to think about when you're seeing these more constricted patients. Another note on lability: if you are interviewing a patient in the morning and during that interview, when you're doing your mental status exam, they don't express any lability, I was taught that that is how you will document it, even if when you see them later on in the day, maybe in the afternoon, maybe they're much more labile. You can add an addendum in your subjective section talking about the behavior you saw. But for your mental status exam, that exam is describing a brief moment in time when you did your interview and shouldn't be carrying data points from other examinations, if that makes sense. The next thing is thought content, and for this, SI and HI, and then the last one is delusions. And a good pimping question that I've come across, at least, is like, what kind of delusions are there? So if you can quickly review this, in the days before your sub-I. I know, so there's easy ones like delusions, like paranoid delusions, and delusions of persecution, or grandiosity, but there's also jealous delusions, somatic delusions, erotomanic delusions. I think there's hypnagogic, no, excuse me. There's a delusion where you think you're dead. Excuse me, let me look that up really quick. Cotard syndrome, where someone thinks they're a walking corpse. So if you can keep a couple of those in your back pocket in terms of like vocabulary knowledge, people will be very impressed. There's also ideas of reference and things of that nature. But for kind of a normal exam, you can just document denies SI/HI, no delusions observed. The next thing is thought process, and I think this is actually the hardest part of the exam, for me at least, to document. It's very easy if you have a patient who fits one of these broad categories. So for a normal patient, I usually put linear, goal-directed, retains reasoning or good understanding of cause and effect. But for a patient who maybe doesn't have a great thought process, but they're not tangential, which is where the question is here, the answer is here, and the patient goes, and they're also not circumferential, which is where question, answer, and they eventually, they take a couple detours, but they do get to the answer. Those can be very easy to identify and can be great for helping you begin to restrict your differential diagnosis towards maybe like psychosis or mania. But if someone has just poor understandings based off of like their paranoid delusions, that can be harder to document. What I've been aiming for is poor understanding of cause and effect, difficulty reasoning, and I spend a little bit more time here because I think there's room to be nuanced, but I haven't figured out a way to be super efficient about it, which is also a critical part about documenting this exam. If you have any tips or tricks, I'd love to hear. The next thing is perceptual disturbances. So this is where you're going to cover the AVH, and also if it's a new patient or newer patient, make sure you're also still asking about somatic, gustatory, and olfactory hallucinations. Another good pimping question I've been asked is, what's the most common type of hallucination in schizophrenia? auditory hallucinations? What's the most common one for drug-induced psychosis? It's somatic. And then what would a gustatory hallucination kind of lead you toward in a differential? And that you might want to consider maybe like a more organic cause. The next thing I have on the list is sensorium and cognition. And for that, you're going to use like very medical terms. So either a patient is going to be alert and awake versus like lethargic or comatose. And these are all medical terms that exist within a spectrum. So as you're writing your mental status exam, just go look that up and kind of get into the habit of using these in the appropriate way. So it looks like it's lethargy, which is where patients can be aroused by moderate stimuli but then drift back to sleep. Obtunded, which is similar to lethargy, but maybe more increased drowsiness. Stuporousness, where only vigorous and repeated stimuli arouses the individual. So a lot of places don't allow you to do this, but this would be kind of like the knuckle rub patient. And then coma is when they're unarousable, period. So I think for most patients who are going to be on an inpatient psych unit, you're really going to see only more of that lethargic patient, because otherwise, you know, medicine's probably involved, and they're more likely, I think, to probably be like a CNL patient. You're also going to document here how oriented they are, and so oriented person, place, time, and situation, and make sure you shouldn't be documenting, or at least you should be really considering how you document oriented to situation, because if a patient, because of these inner delusions, can't really explain why they're on the unit, then even if they are very cogent in many other aspects, they're not oriented to situation, and that's going to help you when you start writing your assessment, so you need to document it that way. And here's also where you can document memory and concentration. Finally, you can have impulse control, insight, and judgment. And so for impulse control, it's kind of like lability. Is the patient doing things that are impulsive? And if they're not doing it in that kind of observed snippet of time, then just document no impulsive behavior observed. And then additionally, for insight, you ask the question, what brought them into the unit, what caused their admission, and that should allow you to assess for insight. Whereas when you ask them, what are your future plans, what is going to be different in the future, that assesses for the judgment. Judgment is about actions in the future, and insight is more about how you interpret your knowledge of the past. And another pimping question I've come across is, you know, what's the best way or the stereotypical way to assess for judgment? And that's the kind of not a great actual clinical tool, but theoretically you could ask a patient, if you were given an envelope with a person's name and a stamp and an address on it, what would you do? And obviously the step would be, okay, well, I'm going to put it in a mailbox and get it there. But in a generation of us millennials where, gosh, I haven't sent something in a while, I think that question kind of has fallen out of vogue, but still just to keep in your back pocket. I hope this was helpful. Sorry the camera's wiggling because it's sitting on my lap. I'll try to go over HPI in another video, and also how to write kind of an assessment, like a psych assessment, in an additional video. And then maybe just a general review of like the expectations that I had placed upon me during a sub-I. Just because I think that can kind of relieve some stress and anxiety if you have one coming up and you haven't done one yet, and you're anxious about what's it going to be like. Alright, anyways, thanks for chit-chatting with me, and I'll talk to you later. Bye.